So I've got a really big interest in trying to improve treatment of infections in critically ill patients, and a lot of that's born about from my practice as a critical care pharmacist, whereby I've observed what I'd call suboptimal outcomes for patients, whereby they end up failing treatment, or alternatively they require really long courses of treatment just because I don't think that we're using the right doses of antibiotics. And so my big history as a researcher is all really based in around that, to try and work out, well, how does the drug behave in those patients? And with that knowledge, what should we be doing from a dosing viewpoint to try and combat that? Some of my early work was based in and around trying to just describe what concentrations of antibiotics resulted from the current doses that we use. And so with those initial studies, which were done in really a single centre fashion, so that quite small, not necessarily very generalisable, we observed that concentrations were quite low. And so because of this suspicion that we had, about 3 years ago we undertook quite a large multi-centre study. There were 68 intensive care units in 12 countries throughout Europe. We enrolled about 450 critically ill patients and did a point prevalence pharmacokinetic study to describe in a broader sense what sort of concentrations of these antibiotics exist in critically ill patients. And what we observed is that at least 20% of patients don't achieve what I would consider to be the absolute minimum exposure of drug. And those patients were 3 times more likely to fail treatment. And for a target which I think is probably a bit more appropriate and more likely to result in consistently better outcomes for patients, 50% of patients didn't achieve that. So that was really quite sobering, but at the same stage it was very important to know that this problem, which we sort of suspected may be a problem, actually on a broader scale was identified to be the case. Sure. So as I mentioned, that data actually was able to, it wasn't powered to show a difference between clinical outcome, we didn't think, but then we actually saw a really strong, statistically significant effect of increasing drug exposure and better outcomes for the patient. So what that suggests to us is that when we are underdosing patients and they have low drug concentrations, they're far more likely to fail treatment, which of course means that, well, we've got to do better. And so our approach is really to try and work out for different types of critically ill patients, because there's a huge spectrum of subpopulations within the critically ill, to work out, well, what doses should these individual patients be receiving. And so we do lots of smaller studies in those smaller patient groups to try and really understand, well, how's the drug behaving, and then what do we do from a dosing viewpoint. Yeah. So we're very fortunate to have a large training grant in Australia, which is all based around trying to understand on a more global scale how to improve drug dosing in different patient populations. It's funded by our National Medical Research Council. It's called the NHMRC, and it's a Centre for Research Excellence in trying to redefine antibiotic dosing. So in that particular grant, patients with cystic fibrosis, burns, obese patients, paediatric patients, including paediatric critically ill patients, and patients that are post-transplant as well, both solid organ as well as haematological malignancy. And we hope that by covering that breadth of patients, that this issue that we've discovered in the ICU, maybe if it exists in those other patient groups, that we can also solve that there. A difference between different drugs, and so the drugs that we most commonly use are the beta-lactams. That's certainly for most infections, that's what we use, and they have a very wide safety window. So for them, using higher doses more generally isn't as problematic. What we do try to do is to identify characteristics in individual patients which suggest they would need a higher dose, which means that we're far more selective when we use a higher dose in a patient, because we know that that's the way the drug's going to behave. For other drugs which have more of a narrow therapeutic window, we're sort of bound by current practice whereby you have to measure the concentration of the drug. So for aminoglycosides, glycopeptides, that we can suggest to be more aggressive with dosing so that we get to therapeutic concentrations more quickly, but we're still reliant on therapeutic drug monitoring to make sure that we're not overdosing. Well, I don't know where to start. It's been a fabulous meeting. There's really lots of fascinating stuff that's been going on. Today, for instance, I was just walking around the posters before I came to see you, and there's some really interesting data about risk factors for patients developing multi-drug resistant infections, and they do differ between the different types of multi-drug resistant organisms, and so there's a lot of learnings to be had there. We've got some really fascinating PK/PD sessions in the next couple of days, as well as a really nice poster session on Saturday, I believe. So there's a lot that I think that I'll take away from that as well. But I've really enjoyed it. Even the session that I was fortunate enough to speak in, the other presenters had some wonderful insights into their own areas in and around dosing some specific drugs, and also what to do in the context of obesity. And it's a great meeting. It's a pleasure to be here.